Welcome to Duke Spine Institute. We're streaming live spine surgery on May 29, 2025. Our patient travels from California with herniated discs in her neck. She's having symptoms from those discs, and we're going to go in, instead of doing an ACDF fusion or an artificial disc or a laminectomy infusion or a laminoplasty or foraminotomy, we're going to go in and do the most advanced surgery in the world, which is the endoscopic laser surgery we do here at Duke Spine called the Duke Laser Disc Repair. The surgery is designed to not only treat the herniated disc, but also eliminate neck pain, radicular symptoms of irritated or pinched nerves, and even pinched spinal cord symptoms. The last cervical Duke Laser Disc Repair we did, our patient was from California. This patient's from California. And the last patient we did was last week. And he was losing strength in his arms, losing coordination of his arms and legs, having balance problems. He's now walking better, and his arm strength is almost back to normal. He's doing fantastic. I just saw him this morning. All right, this patient has been here before. She came for facet pain in the past. Now she's having her discs repaired. We're doing 2 discs, the top 2. She has 4 discs that are damaged, but the top 2 are the ones that I believe are causing the vast majority of her symptoms. We don't just operate on discs because they're abnormal on the MRI. Can you give me more extension? Can you give me more extension? Let me know when you're ready. So maybe, does she have a shoulder bump?
Yeah. Yes, she does, and she also is on a gel belt.
All right, so the way we do the surgery is we access the spine and the disc through the front. That's the best way to do it for any surgery. 2, 3, 4, 5. So we're doing 3, 4, 4, 5. Everyone agree? Need to be a little bit higher. She's completely relaxed.
Yep. You want to grab her chin? Yes, sir.
Shot. All right, 3, 4, 4, 5. Shot. That's overexposed. Jordan, help us. Come on. Shot. All right. Give me, let me see. Shot. Shot. AP. Have to get into the disc through the front. No. All right, lateral. Shot. 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 AP. I'll talk to you guys in just a moment. That's perfect. Lateral. Shot. Shot. Gosh, guys, we need to do a better job with getting extension. Not right now. Shot. All right, give me a Coker AP. Sorry, folks, I am focused right now and busy on trying to get this needle positioned perfectly. If we get the needle done right, then the surgery goes perfect. Okay, perfect. The tip of the needle is dead center, right in the midline. You can see that. Patient is intubated under general anesthesia. You can see the endotracheal tube marking, as well as an esophageal temperature probe. I don't know what we did on the extension of this patient's neck, but shot needs to be done better. Okay, shot. You guys need to have a bigger shoulder pillow. Bigger pillow behind the shoulder to bring her further forward so her head drops back in extension more. Okay? No, it's too late now. 2, 3, 4, 5. Everyone agree we're at 4, 5? Shot. That time has passed. Shot. All right, we're inside the disc. This is the first disc we're going to repair. It's number 4, 5. Then we'll go up to the 3, 4. You could see on the MRI that she has 4 damaged discs. We're not fixing 4 discs today. That is too much surgery to do in one day. I can only do 2 or 3, so we chose these 2, and I think these 2 are going to be the most important to fix. All right, doing a discogram shot. A lot of scar tissue in the back of the disc. It's basically blocking my dye from getting out of the tear. All right, good. So if you have questions, I'll be happy to take them. But this patient injured her neck at work. She was a workers' comp case from California. We originally treated her facet joints. She got a lot of relief with that. Now she came back to get the disc fixed. We did not treat her disc the first time. We just did her facets. Now we're fixing her disc. 2 of them. Any questions, Henry?
Yes, we have about 2 questions. These first 2 questions are coming from Ramazan on YouTube.
Sure.
First question they asked is, "Hi, Dr. Duke.
Hi.
I have a disc degeneration, osteophytes, spondylosis, spinal canal narrowing at C5, 6, and 7. Do you offer a permanent treatment for these? Also, my headaches are coming from C2, 3 or related to C5, 6, or 7.
Well, Ramazan, we do have a permanent treatment for neck pain and radiculopathy. So consider that answer carefully. And I'm happy to do an MRI review with you. See what's wrong.
Next question from Ramazan asking, have you treated...
Hold on a second.
Not a problem.
Where is blood pressure? We need to bring it down. Let me have it, please. Go ahead.
Next question from Ramazan asking, have you treated patients with multiple issues at the same time at C5, 6, 7 like mine? What was the success rate for those cases, and what is the risk of reoccurrence after your treatment? What risks if I don't have surgery?
Tube. Well, Ramazan, I appreciate you asking such a complicated question, but all of our surgeries have been successful, every single one of them.
You want to do an IP first?
No, I'm already in the middle. All of our surgeries are successful. I would say 100%. And remember, what we're treating is a specific problem. Okay? So if you're looking for your spine to look normal after surgery, it won't.
Yeah.
Once damage happens to the spine, it's always going to look damaged. The point we want to do is we want to fix the symptoms related to the damage. So if your symptom is neck pain, we can cure the neck pain. If your symptom is headaches from the spine, we can cure the headaches from the spine. If your symptom is radiculopathy, we can cure the radiculopathy. If your symptom is myelopathy, we can cure your myelopathy. So we cure symptoms. We don't cure radiographic findings. It's very important to understand the difference. Nobody should ever be just curing radiographic findings. Okay? That's not how surgery works. I need extension. Inline traction and extension. Shot. 2, 3, 4, 5. Jordan, you're overexposed. Shot. I know you've been watching a lot of our surgeries, Ramazan, so you're very familiar with our philosophy of treatment, which is we're not here to make your spine look normal. We're here to make you feel normal. That's very important to understand the difference. There is no surgery in the world that's going to make your spine look normal, no matter what surgery you do. If you can tell me a surgery you're considering to make your spine look normal, I'll tell you why it won't look normal. Shot? This surgery right here gives you the greatest chance of having a normal feeling spine and a normal looking spine. All right, I think I need to make the incision a little bit bigger. Knife. Yep, lift the tube up. No, this tube. This tube up, pull it up. There you go. Stop.
Can you see there? Yep.
Yeah. I made her incision just a millimeter too small. I made it 3 millimeters instead of 4. So I added another millimeter to get the tube down. We're going to do the whole surgery through a 4 millimeter tube. Shot? All right. I need some inline traction once again. Any other questions?
At this moment, no current questions.
So at this point, 2, 3, 4, 5, why don't we show our video on how disc injuries are actually let's talk about, first of all, the 30 different causes of neck pain. Because this patient's had 2 discs and a bunch of facets causing her neck pain. We've already fixed the facets. Now we're trying to fix her disc issue. Yeah, she's got very spondylitic discs. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. All right, welcome back. So we went over 30 different causes of neck pain, right?
Yes, we did.
And what's interesting, if you look at that video, the 30 causes of neck pain happen to be very similar to the lower back pain. And there is some differences though. One of them is you don't have an SI joint in the neck. You also don't have a piriformis in the neck. Look at all this herniation here. Oh my God, there's a couple of pieces. These are hard, like little rocks. And they just sit in here and press on your nerves and cause inflammation. But these little rocks, they're all calcified pieces of herniation. This poor woman's injury to her neck caused this, and she's been suffering for years as a result. Like I said, she came from California. We've already done some surgery on her spine, but she needed a lot done, and now she's back to get some of the other stuff we didn't treat the first time treated. So it's not uncommon for our patients to travel here and get some things fixed and leave some things for later. All right, there's nothing wrong with that. I'm trying to float this piece of herniation, but it's very calcified and it's very dense. So what that means is it's heavy, like what you would call heavy. It wants to sink to the bottom. It doesn't want to come up and out. By the way, at 12 o'clock is the laser fiber. You guys see that laser?
Yes, we do.
That laser fiber is 1/2 millimeter wide. So get an idea of that. That's how much magnification you're seeing through this tube, through our endoscope. The fiber is being magnified so significantly that 1/2 millimeter or 450 microns of fiber looks big, but it's not. It's really tiny. So this surgery is extremely precise. Plus, with the endoscope, I can see right at the back of the disc where the bone spurs are, and I can see where the herniation is. I can see the spinal cord, if the spinal cord is visible, which we don't want to see the spinal cord, but sometimes we do. And you can see nerves, ligaments, bone spurs, pieces of herniation, scar tissue, stenosis. You can see everything you need to see. Better than any other type of surgery in the world. You can see it better with this system. All right, any questions?
At this moment, no current questions.
Then in that case,
Yes.
let's show our audience how disc injuries can be so painful
Perfect.
and what we do to treat them.
Copy that.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 millimeter skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
All right, well, welcome back. You can see from our video how the Duke laser disc repair works to fix the source of the herniation, which is the tear in the back of the disc. I want to point out to you, earlier I said just a few minutes ago, we don't want to see the spinal cord, but we can sometimes. And in this case, we can. I'm going to show it to you right now. It's right here below this. See that right there? That is the spinal cord right at the tip of the laser.
Yes,
Now,
we do.
look at how the herniation is pushing right on it. Okay? So that's why we had to do this surgery here. Because these herniations can get so bad. And by the way, this is horrifically destroyed disc. This is a prime example of what we call degenerative disc disease in the disc, in the neck. And it has a special name. In the spine, we call it spondylosis. Okay, so when you have degenerative joint disease in the disc, it has a special name called spondylosis. That's what it's called, spondylosis. Now, why do we have so many names for the same things? I don't know. I didn't make this stuff up. Other doctors do. It's superfluous. It means that it's redundant, unnecessary, excessive, superfluous. We have too many different names for the same thing when it comes to disc injuries. And honest to God, I've never seen it anything like it in medicine. It just happens with disc problems. So degenerated disc, herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc. All those names are for the same thing, a disc injury. The disc is literally, of all the problems in medicine that we see, hepatitis and complex viruses and cancer, the disc is the easiest to understand. And yet it's eluded scientists, doctors for hundreds of years, thousands of years. Yet it's so simple. It's only two parts to the disc. There's the wall, and then there's the jelly. Some people say the end plate, but I don't agree. The end plate's not really part of the disc. The end plate's part of the vertebral body above and below. The point is, the disc is the easiest, simplest structure in your body. It's literally a collagen elastin wall and a material that basically contains a lot of water and proteoglycans and glycosaminoglycans, which act as a shock absorber. But that's really your remnants of your notochord, okay? So simple structure, and yet so many different names for the same problems, right? Damaged disc is just a herniated disc. That's the right name for it. And yet so many different descriptive names, you know, bulging disc, extruded disc, ruptured disc, protruded disc. I mean, it's all the same damn thing. All right, just about done with this one. And then we're going to move on to disc number 2. But there's a lot of scar tissue here. This white stuff is all scar tissue sitting right on top of the spinal cord. So I just have to be really careful. I've gotten all the herniation out. There's nothing left here but scar tissue and some bone spur. And I'm very happy with our results. Any questions?
At this moment, no current questions.
All right, very good. In that case, we're done with this. We're going to move on. So we'll move to the next disc, which is going to be the C3-4, one above. A little antibiotics. Now, the reason there's a little bleeding is because, remember, we didn't just take the disc herniation out, we took some bone spurs out. Anytime you start taking bone spurs out, you're going to get bleeding, because remember, bone spurs have bone marrow. You guys understand what I'm saying? Like a bone spur is bone, right? So there's going to be some bone marrow in there. And bone marrow, that's where your blood cells are made. So you're going to have blood in the bone marrow of the bone spur. You start zapping away the bone spur, you're going to get some blood coming out from the bone marrow. Any questions?
Yes, we have a question coming from Charlie on YouTube.
Hi, Charlie. Welcome once again to our live stream from Duke Spine Institute.
Asking, I watched a Dr. Cole Kim used to do laser endoscopic approach at the L45 and L5S1, but with a side emitting laser. How is that different from your device?
What? How is what?
Yeah, side emitting laser. How is that different from your device?
Well, if you're just talking about lasers, the side firing laser is different than a straight firing laser. One shoots the laser energy out shot. One shoots the laser energy out the front, the other shoots it out the side. The side firing laser has a lot of disadvantages. One of them is you can't really see where you're shooting the laser beam to, because you're shooting it to the side. And that's what the Koreans used to use. They used to use the side firing laser shot. And what happened was they ended up side fire lasering the spinal cord on a couple of patients who got paralyzed from the surgery. So that's why one of the reasons I don't use side firing, you can, with straight firing, which is what I use, you can actually see exactly where the laser is going to shoot the energy. It's right in front of you. You can't miss it. But with side firing, you can miss it. And obviously, it's the Koreans who are masters of side firing for years. They had some serious problems. Shot? All right. Right on the bone spur in the front of the spine. And now we're out. I'm going to move up. This is called the Duke Spine Slide. We are the first in the world to do this. Move the dilator up the spine or down the spine to the next disc. When I learned anterior transdiscal endoscopic surgery from the Koreans, Dr. Sang-Ho Lee, Dr. Gun Choi, the leaders, pioneers, the ones who pioneered anterior cervical transdiscal surgery, they only treated one disc at a time. So I've treated 4 discs at a time. And that's because I can move the device, my probe, up or down in a process called the Duke Spine Shuffle shot. And if you know what you're doing and you do it carefully, you can actually treat more than one disc. All right, let's see if we're on the AP again, if we're in the middle. So besides side firing, shooting to the side where you can't see, and straight firing, shooting straight where you can see, the other thing you need to understand, wait, come back. Is the neck straight? The head's rotated, but is the neck straight? It looks pretty straight. Shot? All right, that's better. We're closer to the middle. Hold on. Right there, shot. All right, good. Lateral. So I'm trying to keep my probe, my tip of my probe, which is called the dilator, I'm trying to keep that in the middle of the spine, right over the disc. That looks pretty damn good right there, here. So I'm going to enter the front of the disc. Now, besides the side firing, shooting into a direction you can't see, and the straight firing, shooting where you can see, which is better, I need to get another AP view because I feel like it's sliding. This is why robots can't do this delicate surgery. All right, good. It slid, but it actually slid into a slightly better position, which I like. All right, let's go. AP, shot, lateral. Good. Got to go up a little bit. Shot. That's better. The other problem with side firing is that it's less energy is being delivered. Less energy. Straight firing lasers deliver all their energy right out the tip, whereas side firing lasers lose energy through the reflection of the energy off the mirror, which there's a little mirror in there that allows it to shoot to the side. Or they bend the fiber. So anytime you bend the fiber, you're gonna lose energy. There we go. There's a tear. You see that? Nice tear right there. Shot. Good job, guys and gals. We're almost done. There it is. I'll take the whole surgery is done through this 4mm tube, by the way. We're going right through the disc to the back where by the way, you can see there's no bleeding and it's a tiny incision. It's an outpatient surgery. You go home an hour after your surgery. Well, you'll get to go home. Most patients, though, travel from around the world, so they end up going to the hotel instead of home, and we check them out in the morning. At this point, I'm going to bring the tube down through the disc, now following the dilator. I've got to keep my eye on that tip of the dilator, make sure it doesn't move in. That would be really, really unwanted. So I think I answered the straight firing versus side firing. Straight firing is what I've used for years. It works. We have a 100% curing back pain and neck pain with the straight firing laser. They don't have that with the side firing laser, not even close, maybe 80%. And there's no reason to change it if it isn't broken. Almost done. But I did try the side firing on several occasions, and I just didn't like it for those reasons. All right. Any other questions?
At this moment, no current questions.
Okay, you can see we're operating on number C34 disc, C34. We just finished C45. This has been a bloodless surgery. The patient won't have pain tomorrow. It'll be gone completely. There's no need for painkillers. We don't give narcotic painkillers to our patients having laser surgery at Duke Spine because they don't have narcotic needed pain. Now, if you have a ACDF fusion or an artificial disc or a laminectomy or any other surgery for that matter, you're going to be on narcotic painkillers for probably weeks. Any other questions?
At this moment, no current questions.
All right. So next week we won't be broadcasting. And the following week we'll be back with surgery.
But that does not mean that we will not be having content next week. We will have plenty to share, plenty to upload, and so just you guys wait.
Yeah, Henry is going to be posting naked pictures of our staff next week.
I was.
What's the issue? Yeah, call Dr. Patel right now. Call Patel. Yep, he needs to do a shot on her hip. Any other comments, questions, concerns, advice? We had one of you viewers tell us we need to do a podcast, and we actually looked into it, and we're going to start doing podcasts.
Yep. We're starting to do that now. We're going to get it all structured for next week, and then try to see if we can get our first episode within by the summer. And so I have a whole plan, getting everything structured. Just you guys wait.
Yeah, Henry is. You actually will be interviewed by me, Dr. Berndes. I'm going to interview you on the anesthesia. I'm going to have Henry do the first interview with me, asking me some questions.
Yep.
And then the subsequent interviews will involve doctors or staff or people of interest. But, I'll be honest, I didn't know what a podcast was. I've heard the term podcast for years. And I thought a podcast was just a YouTube video. That's it. Like, two guys talking on a YouTube video. I didn't realize that it was something you post on Spotify, that's the platform for podcasts. But that's what we figured out last week. And Henry is getting our Spotify account set up this week. Right, Henry?
Of course, correct. We'll have that. We'll have
and
everything
then
ready to go. Yeah.
Henry's going to look into how we go about posting our podcasts. We're going to create a Duke Spine channel on Spotify for those of you who like Spotify. And we're going to start streaming content, basically. So thanks for the suggestion. I think it was Scott or Jeff.
I think it was Scott, or I think it was Charlie who suggested that.
Maybe it was Charlie.
Yeah, one or the other. Either way, thank you guys so much for suggesting that, and making us push forward with that. I am very, very excited to
me too.
get this started and see where it goes.
All right, we are at C34. You can see the appearance of this disc herniation is very different than the last one. The last one, the disc was super collapsed, lots of scar tissue, a lot of bone spurs. This one is more fluffy herniation. That's what we're working with the laser right now. Once again, you can see the back of the disc. You can see the epidural space right there. And so far, this is everything's going really good for her. We're going to be done in about 10 minutes or less. This is 2 discs we fixed for her. Now, I had to pick the 2 worst discs because I couldn't fix all 4 at the same time. All right? Just two too difficult, too risky in my opinion for her, with her types of herniations, how degenerated they were. I didn't want to take the chance of creating a complication. A good surgeon always weighs risks over and benefits of each procedure. A good surgeon is going to look at the patient, look at their problem they're having that they have to fix, and then look at their medical comorbidities and look at his or her team. Like, who does he have available to help him? Do we have all the right supplies? Do we have the right people? They look at all these factors to really figure out what is the best that we can do for this patient given what we have, right? And that's a judgment call. Every surgeon is different. Every surgeon makes different choices based on their resources, based on their experience, and based on the patient. So when I looked at her neck, I realized there's 4 discs, but I don't think all 4 are equally bad. I don't think all 4 are all causing the same amount of symptoms. So I went for the 2 that I thought were the worst. And if you look at C3-4, to me it says, hey, I'm the main culprit. I'm the one who's causing most of her problems. So then it's natural to go after C4-5 because C3-4 and C4-5 are next to each other and they're pretty straightforward to fix both of them. All right, you guys see that? Oh, there's a piece of herniation that just came out. Big one.
We see that, yep.
It's coming up and out. So once again, the other disc we did, the first one had a lot more bone spur. This has more herniation, more like recent herniation, just a couple of years old. Oh, there's another herniation. It came out right where the nerve was. You guys see that? That was in the foramen. That was her left foramen. There's the spinal cord and her nerve root right there. That is so damn cool, folks. That's why I love this surgery. If you do ACDF surgery, you'll never see this. This is more detail. We're going to be done in 2 minutes, Dr. B. Oh, and then Patel, is he on his way? All right, you guys see that? That's the nerve root right there. So if this is 3-4, that's the C4 nerve root.
Well, you can see it.
Okay? I'll show it to you again in just a minute. I'm just cleaning everything up beautifully. The spinal cord is right here below this. That's called the PLL, posterior longitudinal ligament. And there it is right there. There's the foramen. There's a little piece of herniation I'm working on. But you can see the spinal cord and the nerve right down there. Now look how precise the laser is. I can remove this herniation right here without damaging the spinal cord or the nerve root. It's really quite incredible. This is only possible with endoscopic surgery. Look at the calcification of that herniation. It's starting to calcify. So there you go. Oh, one last piece of herniation right there. It just came out. There's the nerve root. All right, there's the nerve root, that white thing down there. That's the dura covering it. Dura, D-U-R-A. That's the protective, tough connective tissue covering over the spinal cord and nerves. Dura. And it covers the brain. Look at that area of inflammation, folks, right where the nerve is. You guys see that?
Yes, we do.
That goes along with our video we showed you. Look at all that red inflammation up there. That's the body trying to heal this herniation, but not successful. Oh, more herniation out of the foramen. That was really far lateral in the foramen. So that was a really good herniation to get out. That thing is sitting on top of her nerve. Look how fuzzy it is. It looks like a polar bear. Why am I thinking about polar bears? Huh? No? Yeah, it does look like a cocoon. Henry's about to tell you.
I was going to say it's white and fluffy.
No. What program am I watching on Netflix?
Not The Witcher.
No, Lost.
Lost, that's what it was.
I don't know if you guys watched it or not, but there's polar bears in there, right?
I've seen clips of it, but not to its entirety. My brother's seen Lost, though.
Ah. Yeah, they have polar bears attacking people. All right. So I got that little piece out. I think we're just about done. All right, but don't ruin it for me. I haven't watched the whole thing yet. I want to see the end. All right, any comments, questions?
Yes, we have a question coming from Charlie once more on YouTube,
Uh-huh.
asking what symptoms downstream the legs would one notice that could have the cause in the cervical
minute.
spine?
Is Patel here? All I heard was what symptoms, what?
One symptoms downstream the legs would one notice that could have the cause in the cervical spine?
I'll be honest, I don't understand the question. What symptoms?
Would one notice that could have the cause in the cervical spine?
Oh. So in other words, if you have a herniated disc in your neck and that's the cause of your symptoms, what symptoms would you have? The answer is neck pain, pain shooting from your neck into your shoulder and down your arm, headaches, any of those symptoms, balance problems, coordination problems with your hands, your legs. Those are all indications of spinal cord compression. All right, just about done. I think that's another piece I can get right there. Oh yeah, there it is. Big dog. Let's grab it. And then we should be done. All right. Any other questions?
At this moment, no current questions.
Got it. All right, we're done. I want to show you all the incision for this surgery. This surgery will replace ACDF, which is also known as anterior cervical discectomy or decompression and fusion. Many of you have been recommended for that surgery. Don't do it. It's unnecessary. It is what I call a scam because the surgeons are recommending it because that's the surgery they make the most money doing as a surgeon. They're doing fusions and artificial discs. It's not good for the patient. Patients should have less invasive surgery that's better for them and has better results. And that's what this surgery is. It's the best surgery for the patient, safest for the patient, most effective for curing symptoms. Long-term results are excellent, better than any type of invasive surgery. And there's no metal put in your body. There's no plastic put in your body. There's no cadaver bone put in here. It's just wonderful surgery. Look at that. Done with a 4mm incision in the neck. Okay? Yeah, here's your tape measure. And like virtually no bleeding. Okay? Just a few drops of blood. This is the future of spine surgery you're watching here at Duke Spine. We've been doing it for 20 years now, going on 20 years. And been teaching other doctors to do it, but they're very slow to adopt. Any other questions?
No current questions.
Thanks for joining us. We'll be back shortly with another